Hello, my name is Andrea Berišić and I'm a doctor of dental medicine. Today I would like to talk about how a young clinician can approach complex cases that call for a multidisciplinary treatment. I graduated in 2022 from the School of Dental Medicine, University of Zagreb. I currently work at Poliklinika Božić, where for the past 3 years I have been part of Professor Božić's outstanding team. Our work centers on the team-based management and rehabilitation of complex periodontal patients. I'm also a member of the OAC Young Committee, which is a scientifically oriented society for young clinicians. A multidisciplinary approach is only possible when the treatment plan is built as a team and when every member of that team delivers their part expertly and meticulously. In our team, the professor performs the initial examination, which is where treatment planning begins, and carries out all surgical procedures. Our hygienist delivers the initial periodontal therapy and oral hygiene instructions. At the first recall, we plan the individual procedures together and arrive at a complete treatment plan, which we then deliver together. My role covers restorative dentistry, orthodontic pre-prosthetic preparation, and the prosthetic and implant prosthetic phase. While treatment is running, we coordinate the procedures so that they interweave, making the best possible use of time and shortening overall treatment, but never at the expense of healing. Once treatment is complete, the whole team remains involved through the recall program. For this lecture, I have selected 4 cases that require the entire team to work together. Case number 1. Our patient is 15 years old female, 51 years old female, and came to us for a second opinion after treatment had already been started elsewhere. She presented with generalized periodontitis, stage 4. You can see the pathological tooth migration caused by bone loss and unstable occlusion, which is a result of the lost molars. Her oral hygiene was not satisfactory, and it remained a problem throughout the entire treatment. So all of us in the team had to keep reinforcing her on oral hygiene and telling her how decisive the oral hygiene is for the outcome of the therapy. At the first appointment, we informed the patient that orthodontic treatment would also be necessary in order to bring her migrated teeth and the collapsed bite back to their original position. The radiograph shows the bone level, the vertical defects, and the fresh extraction sockets. It was taken after endodontic treatment of tooth 11, which had presented with pulp necrosis. In the first phase, we performed initial periodontal therapy together with the endodontic treatment of tooth 11 that I mentioned before, and the retreatment of tooth 43. After healing, we waited for her oral hygiene to improve before the professor carried out regenerative surgery at teeth number 23 and 15, which was again followed by a healing period. The second phase after healing ran implant placement and orthodontic treatment in parallel. The implants replaced the missing first molars in the first, third, and fourth quadrants, while in the second quadrant we planned the bridge. At implant site 46, Volumax was used to augment the buccal bone. While waiting for osseointegration, we began the orthodontic treatment. The aim of the orthodontic treatment here was to restore the position of the upper anterior teeth and to bring the posterior teeth in a better position, allowing more conservative preparation and a better distribution of abutments. We also increased the vertical dimension because the anterior teeth were in occlusal trauma and we had no space to even move them. In patients like this, we always begin with the thinnest nitinol wire because of the reduced periodontium. The photographs at the top are somewhere from the middle of the treatment. The right side is stabilized, the teeth are upright, and the diastemas remained on left side. We now move one tooth at a time, while the teeth, which are already in a satisfactory position, are tied together with a steel ligature, and they serve as an anchorage. The teeth 22 and number 23 were mesialized, and tooth 25 was distalized. The right side remained in crossbite because we lacked posterior anchorage for arch expansion, and we were limited by the nitinol wire properties. So on the lower photographs, you can see the results of orthodontic treatment. The third phase is the prosthetic phase. Prosthetic work is also responsible for maintaining everything we have achieved because poor emergence profiles on implants or imprecise restorations that retain plaque or leave no room for cleaning, and an unstable occlusion can jeopardize all of the results up to that point. The implants were restored with single screw retained monolithic zirconia crowns, and in the second quadrant, we chose a metal ceramic bridge because of the long span. The anterior teeth were left natural with minor conservative corrections. These photographs were taken at the first recall after treatment was completed. Now the patient attends her recalls regularly for the past year and a half. Her hygiene has improved, although it is still not ideal. Despite that, there are no active pockets. But unfortunately, I do not have more recent photographs, so my apologies for that. You would have to trust me. And now on to the second case. It is also a female patient that is 54 years old. She came to us because even after a regular periodontal treatment, she felt the disease was not under control, and also for the aesthetic reasons. Her studies showed a stage 4 periodontitis with deep intrabony defects expanding beyond the apex around tooth 42. Tooth 16 was non-restorable, so we decided on extraction. About the aesthetic concerns, I believe they are visible in the photographs. The first phase was initial periodontal therapy, removal of the old bridges in the lower anterior region, and endodontic treatment. Once the bridge was removed, we reassessed tooth 42 and decided to save it. And endodontic treatment was carried out on teeth 41 and 31. Well, excuse me, not 41, 42, the tooth we decided to save. We performed endodontic treatment, also on number 31, and in the upper jaw on 21 and 15. Socket preservation was performed at site 16, and after the first recall, we also performed regenerative surgery at tooth 42. Following the healing period, site 16 was restored with an implant placed together with an internal sinus lift. After osseointegration and healing, we moved on to the prosthetic phase, combining materials and types of restorations. In the lower anterior region, we made a new zirconia bridge as well as one on the upper left from 24 to 27. On the implant number 16, we placed a screw-retained zirconia crown. For the anterior teeth, we produced a digital wax-up after removing the old restorations. The photographs show the mock-up before preparation. From tooth number 14 to tooth number 23, we plant single crowns and veneers in lithium disilicate ceramic. Excuse me. Okay. Um, we ran into a problem with the shade of the prepared central incisors, which were green. Concerned that the dark, non-vital preparation would show through, I decided to mask it with an opaque shaded composite, which in itself proven to be the challenge for the technician as well. These were the results of treatment at the first recall. Sufficient access for cleaning was left everywhere. In the end, the central incisors were made from low translucency zirconia because of the stump shade. Firstly, we tried with ceramic, but it was see-through, and we needed to change into something more opaque. This patient has been attending recalls regularly for the last 2 years now. Her hygiene is impeccable, and there are no active pockets. So the periodontitis is completely stable now. Everything went smoothly in this case thanks to her high level of motivation and her excellent hygiene, which is what made results like this possible. Case number three. It is again a female patient, as most of our patients at the clinic are. She came to us wanting to replace her all prosthetic work. What she didn't know was that she had stage 2 periodontitis and that several abutment teeth beneath the bridges had failed. As you can see on the radiograph, tooth 47 had a root fracture, so immediately we knew that it would have to be extracted and that we would need an implant placed in that region. The first step was to remove the old restorations, of course, so that we could see the full picture. Once they were off, periodontal treatment began alongside prosthetic planning. We made laboratory temporary bridges. We also attempted retreatment on tooth 26, but it had a large perforation in the trifurcation area and it was not a candidate. You can see the perforation here in first photograph. So at the same appointment, tooth 26 was extracted and crown lengthening was performed on tooth 25 in order to obtain a ferrule. On tooth number 14, socket preservation was carried out. In the second phase, after healing and the first recall, implants were placed at sites 14 and 15 with an internal sinus lift and buccal bone augmentation using Volumex. An implant was also placed at site 46. The prosthetic plan was demanding because we were combining teeth and implants. Of course, we were not splinting them together into tooth implant supported bridges. All restorations were zirconia ceramic with the exception of the lower left bridge, which was made in metal ceramic because of the long span and the curvature of the ridge. So in the upper jaw, we made an implant-supported bridge from number 16 to 14 and zirconia crowns and bridges from number 13 to 27. In the lower right, a single crown on tooth 45 and a single crown on implant 46. These are the results from the first recall after cementation, which was 5 months ago. So far, the situation is stable with no active pockets, but this is a rather newer case. Case number 4, I say the most complex one for the last. It is a young patient with a significant aesthetic problem. Tooth number 11 had been missing for many years with loss of buccal bone and a severely narrowed mesiodistal space, which made any straightforward reconstruction impossible. She was wearing a denture which had cracked, And her oral hygiene was far from satisfactory. And also, she had dental anxiety, so a lot of problems. There was extensive caries and several retained roots that needed to be extracted. This is a photograph without the denture. Now you can clearly see how narrow that space is, and the problem with tooth number 12, which is rotated. And it was vital. To begin with, we wanted to eliminate the denture since it would have interfered with healing after implant placement. That is why we knew that we had to start with tooth number 12 as the abutment for a provisional crown and place the implant. We also needed more space between teeth number 12 and 21, so orthodontic treatment was indicated. Our original intention was to refer the patient to the orthodontic specialist who would organize the complete occlusion and open up the space for the implant. But the patient declined because of her dental anxiety. She didn't want to go anywhere, but she wanted to stay here in our clinic and let us do what we can. So the first phase then was endodontic treatment and post and core buildup on tooth number 12 so that the patient could receive provisional crowns at the time of the implant placement. The preparation was deliberately angled on tooth number 12 with the planned distalization in mind, which we would achieve by tipping the tooth, that is, by rotating the tooth, rather than by torquing it, because we cannot torque with nitinol wires. A narrow diameter implant, 3.5 by 8.5 millimeters, was placed with simultaneous reconstruction of the buccal bone with a PRF membrane. And we planned a two-stage protocol here. After osseointegration, we moved on the second phase, which was the orthodontics. Firstly, we made a laboratory temporary screw retained crown for the implant. On the left side, the diastemas had closed spontaneously once we removed the denture, which worked in our favor. You can see on the photographs, the left one is from the beginning of the therapy, before the beginning of the therapy, and the right one is right before. It was when I scanned for the temporary screw retained crown. So there are no diastemas. On the right side, I gained space between teeth 14 and 15, where there was caries. So before the appliance was placed, we restored those teeth and left a diastema, so we would have space. We then began distalizing the teeth from number 14 to 12, one at a time, with the more posterior teeth serving as anchorage. In these photographs, you can see the poor oral hygiene and further caries and retained roots. So we saw all of that. Don't think we are just ignoring it. But the patient was constantly refusing to have it treated and was not showing to the appointments. Looking back, as a team, we were perhaps too invested in this rehabilitation. We accommodated her decisions rather than setting a firm condition that restorative treatment that must be completed before the orthodontic treatment started. This is the situation at the end of the orthodontic treatment. We were satisfied with the space we gained. The crown on tooth 12 is considerably widened now in order to secure retention so that it doesn't go back. The next step was a free connective tissue graft on the buccal aspect of the implant in order to thicken the tissue and so we can shape the emergence profile on the implant. This is the current result, and as you can see, this case is not finished and it has taken a long, long time. It's because of the patient's low motivation and her satisfaction with the current provisional crowns. So she loves it, and it is a very big improvement than the situation we had at the beginning. Um, she's constantly being postponed. The treatments are constantly being postponed by her. So in the meantime, we have carried on restoring the remaining teeth, and we placed an immediate implant. I'm sorry, my camera died, so I had to pause. So, okay, um, from here, from this situation currently, we plan to open up the space between tooth number 12 and the implant in the hope of gaining a papilla. So we'll see what will happen with the papilla, and then when we are okay, so when when we are satisfied with the soft tissue, we can then fabricate the zirconia crowns. So in the end, what can a young doctor do? In all four of these cases, the surgery that carried out a result was not mine. What was mine was the restorative and prosthetic phase, the orthodontic preparation, and just as importantly, the coordination that held the sequence together. That is the first answer. A young doctor can carry real responsibility inside a team, provided the plan is made together and every step is documented. To work on these kind of cases, a young doctor firstly has to have a lot of knowledge and has to be led by evidence-based medicine or dentistry. After having knowledge, he has to have experience or to learn how to make decisions and critically think. In my case, I had this opportunity and maybe, let's say, this luck to work with Professor Božić, who is very experienced and who has all the knowledge and is always listening to the evidence and the research. So I had like a very, very fast curvature of learning. And also, we have very complex cases. So, from the beginning, I observed his way of thinking, his way of making plans, well, for treatment plans, and I tried to implement those ideas, his way of thinking, into mine. The second answer is about sequence. In every one of these cases, the prosthetic goal was defined before the first incision, where the implants placed, where we placed the implants, how many abutments we needed, how much space orthodontics had to create. All of it was decided by where we wanted to finish. And because we planned as a team, the phases could overlap. Orthodontics ran during osseointegration, and restorative work ran during healing. That is where treatment time was saved without ever rushing biology. All that is possible when the doctor is very dedicated to the patient. So when he prepares before he sees the patient, he prepares for what will happen today and what will happen in future. So a lot of planning is made about the patient, but without the patient. Finally, in the end, I would like to thank everyone who has watched this lecture and also thank my mentor, Professor Božić, from whom I've learned a great deal. He shaped me into the clinician I am today and placed a great deal of trust in me. Also, he treats me with respect despite my or his age and experience. I am available by email for any questions and suggestions. Thank you and goodbye.